Hey team, welcome. In our video lecture for today, we're going to break up into a few parts. And so this is going to be covering the patient assessment section, regardless of what chapter number that is in your textbook. The information here is coming from what's called the focused slides. And there's actually two parts of this that we're going to cover. Maybe more. I'll break it into chunks so we can get it uploaded. So this is a lot of information, hence the multiple parts. The idea here is we're going to give you information that you'll use to assess essentially every patient to varying degrees. Now, there's a lot of information here, and some of it you're not going to be applying right away. So where will you apply it? Well, you'll be applying these things when we get to the point of managing patients, excuse me, and discussing them in the actual theory course. So as we talk about a disease, we'll talk about how we assess patients using these tools when we're assessing a patient for cardiac situations. Same thing with trauma. We'll talk about trauma assessments for traumatic emergencies. And then you'll be using these for the particular chief complaint and call type, medical or trauma, in your scenarios, and eventually it'll become part of your field practice. So what you do in the lab class is what you're going to be doing in the field. Don't think that suddenly you're going to have some epiphany in 5 years when you're working with a patient, remembering a slide that I covered today. So in order to make this stuff things that you're going to utilize in the field, you're going to want to make sure that you're practicing them because what you practice in lab will become your practice. So we've covered some of the components of this, so some of it might be a review, but I'm going to try and hit up the major points throughout this whole section since I don't need to rush through it. So there's 5 major parts of assessment, so they kind of go in line with our major style of a call. So first we have our call coming in one like as dispatch, right? So something happens to the patient, somehow someone calls 911 to let us know. We're notified, all right? So we start assessment right at that point. And then next we start to respond. We're going to go through kind of, we're getting close, so a neighborhood view and then a windshield view, right? What's the scene look like as we drive up to the call, but before we've made patient contact? Before we make patient contact, but after we've gotten out of our truck, so maybe this is at the door. This is when you lay eyes on the patient. We're going to talk about something called a doorway view. And then we start our primary assessment, and then we go down to the call. Maybe we transport, we go to the hospital. Maybe we don't transport, we go off, and this is a refusal. Either way, we're still going to have to do an assessment so we can understand what's wrong with the patient. So these are the 5 major assessments that we do in that kind of progression through a call. Scene size up is going to be looking at things that include scene safety, but it will include the windshield view where you start looking at how do I access this building or this patient, where are my exit points, what safety concerns do I need, what am I thinking about for the units that are maybe not here yet but are responding? Do they need to know something particular about driving into, maybe this is a cul-de-sac, so we don't want them to all drive in and block us in. So a lot of things go into this. Remember, scene size up actually never is a check off. You're going to do it, and you're going to do it because the scenes are going to change. And when you're in the back of the ambulance, that's still an opportunity for your scene assessment or safety assessment. So scene safety is part of that. Now, the doorway view in particular is something that I particularly teach, but it'll help you. The doorway view is going to sit between scene size up and primary assessment. So I'll give you a gist of that in a moment. Primary assessment is what we learned as being our A, B, C, D, E section. History taking, so we'll learn how we ask histories. Histories are going to happen during or after our primary assessment. Secondary assessment is going to be in more depth. So when we're charting, this might be written as a 1 with the degree sign, this with the 2 with the degree sign for secondary. Secondary assessment is, I know my life threats. That's the goal of the primary assessment. So now let me look deeper and try and find things that aren't life-threatening but maybe contributing, or find life-threatening things that just hadn't presented themselves in my primary assessment. And then finally, we do reassessment. So even if we start transporting, we've done our primary and secondary assessment, we're going to continue to do reassessments all the way through to the hospital, and we'll assess the patient as we're turning them over to the hospital as well, so that we have a clear picture that should match the hospital's picture of what the patient was like when we dropped them off. Now, signs and symptoms are specific terms, okay, so we need to make sure we understand what they mean. Signs reflect a thing about a patient, something they describe that is objective, right? Objective means it can be observed. If I look at a stop sign, I know that it's a stop sign. If you look at a stop sign, you should know it's a stop sign because it looks exactly like what we've learned is a stop sign. So it's something that we can see that doesn't rely on someone's description to tell us about it. Symptoms, on the other hand, are subjective. Okay, so they're specific to the person that's experiencing it. So pain is a really good example of being a subjective symptom. So symptoms someone has to tell you about. You can't get by looking at a patient. Maybe I can tell a patient's in pain by looking at them, but I don't know what kind of pain, how much pain, where that pain is. And in truth, many patients are in pain a lot, and they may be able to hide it really well. So truly, you can't really tell truly without their input whether someone's in pain just by looking at them. So it's important we know that because subjective means we rely on the patient describing it. So open-ended questions are going to be key to that so that they can use their words to describe what's going on. A sign is something that I can see. Well, let's use something here that's kind of example, right? Nausea and vomiting. I might be able to see someone has got signs of nausea, but someone could totally be nauseous and have no outward signs that we can see whatsoever. So in the case of nausea, nausea is a symptom. But when somebody throws up, if I'm present, I should be able to see that, right? I should see vomit out of them, out of their body, coming out of their body, on their clothes. I can recognize vomit when I see it, so that's a sign. Signs and symptoms often go together. And so really, we don't really describe diseases as having one sign or symptom. There's many signs and symptoms that actually are present in a variety of diseases, but often there will be some that will help us narrow things down. But none are going to be by themselves a trigger keyword that you can ask one question and know everything you need to know about that condition. Instead, we need to paint a picture, and we'll do so with our skills. So let's start with scene size up. So scene size up is what you're taking into account as you drive up to a call, and that starts with dispatch. So based on what they tell you, and again, it may or may not be accurate, and again, virtually never the dispatcher's fault. It's just the difficulties of trying to manage getting information on the phone. But in the sense of getting a scene size up, I want to know, where am I going? What part of town is it? How far away from the hospital is it going to be likely? What type of condition are they reporting? And what other resources might I need in order to help me do this job? And again, you may not know all the resources, but you'll get a feel. We have a little bit of an idea when we start treatment here too, based on scene size up. You want to ask about or determine what resources are going to be needed, because it's easier to request resources en route, thinking you need them, and then cancel them on scene as soon as you get on scene. If you feel like you don't need them, maybe the dispatch information didn't paint the right picture, then to need them and request them when you're already on scene. Because if you request them when you're en route, you have the time of you responding and the time of them starting to respond. So they'll be there pretty quickly. So if you need ALS for a call, you need to dispatch them the sooner the better. So again, I can always cancel them if I don't need them, but I'd rather not be in a situation where I arrive on scene, oh, realize I need ALS, and now I've got to be on scene with this patient, manage them without all the right tools, and wait the time it'll take for the ALS unit to respond. So if I can get them en route, it'll cut down the time frame it'll take for them to get on scene. Always, always, always check scene safety. So the order of scene safety is number one is you, right? You as the provider. You're the most important person you need to be aware of for scene safety purposes. Okay? Number two, your partners. And number three, everyone else. And hopefully that includes the patient. So I say that because sometimes patients are the threat of our safety. And so I and my partner need to be safe first, then followed up with everyone else. Now, certainly this sounds a little odd, but think of the idea, if you get injured, right, when you call for help, if you've been injured and there's also a patient that's been injured, right, that you originally were going for, every resource that's going to come to help once you call for help is going to go to you. And then whatever's left over will go to the patient. We're going to respond and care for our providers first and foremost. And once they're safe, we'll help everybody else. So that's really like the application of that idea. Determine what the mechanism of injury is, MOI, we'll talk about that in detail in trauma, or the nature of illness. And so nature of illness and mechanism of injury, these are basically for medical and trauma, mechanism of injuries for trauma, medical and trauma, what's the gist of what's going on here? And so it may be different from their chief complaint or their injuries, but it is helpful because that will kind of outline what we're going to be doing. And sometimes we need to think ahead before we get on call, what medications we're going to be referencing and so on. So your scene size up gives you some of that opportunity. Always make sure that you've got your right PPE. That's what the precautions here are. And then determine a number of patients. That's actually a checklist point when you're doing a patient assessment or running a scenario. It's true, scene safety never ever goes away. So we're going to be worrying about scene safety when we're in the station, when we're in our ambulance between calls, when we're responding to calls, when we're on call, when we're off of a scene with the patient in the back of your ambulance, when we're driving to the hospital, when we're at the hospital, when we're driving back to wherever it is that we're posted. So it can change at any moment. And it's unforgiving. It won't matter that you didn't see something. If something's coming to hurt you, it will hurt you, regardless of how well you perform in other areas. So you need to make sure that you're always prepared for safety. Now, there's some points here that you can look at and ways you can manage safety, but I want you to more appropriately, every time you have a call in a scenario, I want you to think of the scene safety things that you need to take into account that maybe aren't verbalized otherwise in the scenario. So walk through them and say them out loud so your team has the benefit of understanding them. Sometimes we can't go into a scene because it's currently unsafe and will probably remain unsafe until some other resource gets there. Law enforcement's a good example. So you're not obligated to lay down your life in order to gain access to a patient. When we have patients, even if we're already on a scene and it turns unsafe, we can leave as long as we intend to come back when the scene is safe. That protects us from abandonment. If I leave a scene and don't have the intention of coming back to help the patient, any harm that comes to them in my absence will probably be under my legal challenge. So if I'm on a scene or en route to a scene and the patient does actually get harm while they're waiting for the scene to be safe and we can enter and care for the patient, as long as we're waiting to go and care for the patient and intend to see them afterwards, we're not liable for the things that happen. So that's to say that first choice is, if I'm responding to a call and I know it's unsafe, I don't want to go to that scene. Patients are emotional, and family members are emotionally distraught by these situations. And so it does happen that we have patients that call 911. It's an unsafe scene that's described to dispatch. So dispatch automatically dispatches law enforcement and tells you to stand by until the scene is safe. Don't drive to the scene and park. Make sure you're clearly away from that scene, stage blocks away, because sometimes it takes law enforcement time to get there. They may arrive when you've been arrived at your staging position. They may arrive a few minutes later. And if you arrive before law enforcement and the family or bystanders see you, they're going to be mad and they're going to start to approach you. So you need to be out of sight of the actual scene. You need, like, totally out of sight. They shouldn't be able to see you. You shouldn't be able to see the scene from wherever it is, because they will find you if they do see you. And you're going to be close enough that once the scene is made safe, law enforcement radios and tells you so, you can respond to the scene. That's best case scenario. Sometimes, though, we get on scenes and we realize then that it's unsafe because dispatch information didn't have that. Sometimes when that occurs, you do have to leave the scene in order to make it safe. So if you leave the scene after already arriving and you can't take the patient with you, as long as you're waiting for law enforcement to come, again, depart the scene, park somewhere safe, let law enforcement clear the scene, let you know that it's safe to go back into, and then once it's safe to go back into, you re-enter and care for the patient. All scenes have the potential for violence, and all scenes have the potential for some type of hazard, whether it's in somebody's home. They can certainly be brewing their own meth lab at their house, which would be hazardous to us. So every type of scene has a different type of hazard that goes with it. So you're going to want to think about, when you're given dispatch information in scenarios, what type of scene considerations you may have, because sometimes those aren't described in the dispatch. When we're talking about determining the mechanism of injury or the nature of illness, a helpful component of that when we're dealing with trauma patients is to think about what caused their injury. What was the transmission of energy that caused the patient whatever injury it is that they're facing right now? That type of mechanism or that type of energy transfer may mean that there's potentially injuries or things in our patients that could threaten their life that are not actually currently diseases or injuries that we can see. So it gives us something that we call later an index of suspicion. So to some degree, we may be able to assess some things and see signs of something broken perhaps, but maybe there's fractures we can't see signs of, or we only have the mechanism or symptoms to rely on. Now again, I'm going to paint that picture for trauma, but just to throw in this term for right now. Trauma is separated into two major types of trauma, blunt versus penetrating. Okay. Was the energy transferred to the patient's body in the sense that it traveled and broke their skin to get into their body? So that might be a projectile, a knife, like a bullet, a knife. Some things become penetrating injuries when there's enough force applied. So think like a two by four that's stuck into the side of a tree. Normally, if I just took a two by four and I threw it at a tree, it wouldn't do anything. But under the right amount of force, like in a hurricane or tornado, the 2x4 suddenly can have enough force to be impaled in objects. So it's really about the surface area. So when we have blunt force trauma, this means that the energy and the surface area of the thing that touched the patient's body, maybe it's a baseball bat, for example, the surface area was large enough that it wasn't enough force to make that object go into the body. So the energy touched rather the outside of the body and then generated a wave that went through the inside of the body. Versus penetrating trauma, it went into the body and also generated a wave through the body. Usually in blunt force trauma, the skin is not broken. It might not even be red at the point that we show up. So sometimes it's hard to identify the internal injuries when we have patients with blunt force trauma. Penetrating trauma, we can see penetration wounds, but that doesn't always mean that we know the direction of travel once this thing went into the body. And so we may be able to see a small defect, but it doesn't always represent the size of the internal injuries, because in some cases, when penetrating objects enter the body, they get larger, or they cause larger damage than they generally would have if it was only blunt trauma. Now, again, all the details of trauma we're going to go through in the trauma section of the course, aside from our definition of mechanism of injury for blunt and penetrating. Nature of illness is kind of like our mechanism of injury in the sense that it tells us about what went on to cause this type of disease or type of sign or symptom that we're seeing. And so we might see somebody who's nauseous and vomiting, but that's not really their nature of illness. Maybe they're vomiting because they have food poisoning. That would be a nature of illness. So it's almost like a diagnosis in some sense, though we may not have a definitive diagnosis. We have an idea of what's going on with our patient. Sometimes this is going to be different than their chief complaint, and sometimes the scene is going to tell us a lot about it when the patient cannot, or other bystanders. Sometimes the actual cause of illness, the nature of illness, might be a hazard to us. Carbon monoxide is a good example. Carbon monoxide is odorless, tasteless, colorless, and so we don't know we're in it until we feel the effects of it, which may mean it's already too late for us to evacuate. And there have been EMTs and firefighters who have died on scene of carbon monoxide poisoning. Now, that's in addition to firefighters who get sick from carbon monoxide poisoning when they're fighting a fire. Carbon monoxide is generally the product of inefficient combustion in which there's not great ventilation. That's usually one of the hallmarks. And so when we fight fires as firefighters, often carbon monoxide is one of the gases we need to protect ourselves with a mask. But we don't always see that as a fire. So an EMT who's not a firefighter may walk into an environment where maybe the oven has been on inside the house for too long without proper ventilation. Everybody there has random signs and symptoms that don't all scream carbon monoxide poisoning at first, but you walk in and suddenly you're exposed to that as well. Consider the mechanism or nature early so that you can determine how quickly you need to go through this call, what resources you might need, and how quickly you need to transport the patient as well. Okay, before making patient interaction, so this isn't when you walk up and see them, you put these things on. It should be as you're getting out of the truck, you put on the appropriate PPE. Now, the PPE is going to be adapted to whatever tasks and situation or threats you have when you're presented with them, so they will vary. And so we covered those in Chapter 2. So remember, be able to know if your patient is squirting blood, what PPE should you gather, all right? And that stuff, again, you should put on before you go on the scene, because once you go on the scene, you're less likely to put it on because you're going to get sucked into, especially with these exposure incidents, you're going to get sucked into treating the patient right away. You're trained to do that. You want to do that very rapidly. We train you to do it rapidly, and you forget to put your PPE on. So again, putting it on before you enter the house and see the patient is always best. Standard precautions, just to say that we assume everybody has every disease, and so we don't discriminate against people that have diseases. We protect ourselves by assuming everyone has every disease and no one wants to tell us about it. Determining the number of patients may be something that's done as you drive up to the scene, could have been told to you by dispatch, but at the very least, once you arrive on scene, you're the definitive answer. Now, if you have more than one patient, greater than one critical patient, you're going to need more than one ambulance to transport that patient. Sometimes we can transport multiple patients in the back of the ambulance. There's some tricks to it. It's always risky. You might miss something. So we never do it with critical patients. If you have one critical patient, that's all you can have in an ambulance. More than that, you're going to need to call another ambulance for. Now, state to your proctors when you do scenarios what the numbers of patients is, and restate it to them so they have it on their points. Triaging is a process of determining if we have more patients than we have resources for. So that's the definition of a multiple casualty incident. How do we determine who gets which resources when? And so if I have a bunch of patients that were in a car accident with 2 ambulances, I'm going to have to figure out who I treat, who gets transported in the first round of ambulances, who gets transported in the second round, and so on. And so we have a very particular means of doing that. For right now, though, we'll kind of just talk about the triaging of sorting patients into different categories. Some situations are going to require access to resources that you're not trained on. And so here we have patients that are specifically in hazmat suits, and these hazmat suits require extra training, hazmat training beyond what we teach here in the EMS program. Often you'll get some of that training in the fire department, but the gist here, regardless of what you want to be, as an EMT, you have certain parameters and certain PPE that you're trained on. Generally, when we're talking about other resources, they're either people that have tools that you can't use because they're not in your scope practice. A paramedic would be a good example of that. Tools that you need more of, and or tools that maybe the PPE or the tools require more advanced training. If you don't have the training on the PPE, you can't use it. It's kind of as simple as that. When determining whether or not you need more resources, you can ask yourselves a few things. Again, this starts with dispatch and it continues on scene. Do I have more patients than I can handle on this scene? And if so, start help as soon as you can. What is the nature of their condition? How severe are they? What resources might they need? Who called EMS? So is this somebody who's first person, and that person knows what's going on because they're the patient calling? Or second or third person or party calls have less degree of certainty? Does the scene pose a threat to me, my patient, or others? And is there some form of PPE or tool that I need to solve this or make the scene less of a threat? All right, so I'm going to pause there, and we're going to talk about something in the next few set of slides that's kind of before primary assessment. Okay, so give me a moment. We'll come back to that. This isn't in slides, but it's going to help you know how to do this idea of a doorway view. Okay, we're back. And so as we transition from the scene size up, which happens as we're driving to the scene, and as we make our windshield view of the scene, taking a look at the scene and then kind of getting a gauge for how safe is it, what considerations do I have as I'm kind of preparing to go in, and what resources might I need to request. We have the doorway view. So your primary assessment is going to start when you are greeting the patient. So this is technically before the primary assessment, okay? I don't want you to think it is the primary assessment because what we're doing here is abbreviated. So what's the goal of the doorway view? It doesn't matter where you are. So if I'm not in a building and my patient isn't behind a doorway or in a doorway, this would still apply. So technically the doorway view is when you first put eyes on your patient, okay? First time you look at your patient. From across the room, you're not communicating with them, you're not talking to them, you're not touching them. This is meant to be a distance assessment. The goal here is to answer the question, is this patient sick or not sick? Okay. If the patient is indeed sick from this assessment, everything we do is to really get this patient towards definitive care. So if patients are sick, we often load and go. So from the point you lay eyes on the patient, you're going to need to determine, are they sick, and does that dictate the entire rest of my call? If I see that they're sick, then I'm going to do things on scene, and those will be dependent on a lot of different things, what the disease is, what my treatment is, how far away from the hospital. But if I know that they're sick, and I know that the fix to this is the hospital, then I don't want to put unnecessary things in there while I'm on scene. To say, I don't want to delay transport to the hospital. If they're sick in the hospitals, they're going to get that care. Even if the stuff that I do is going to help them along the way. If it's not definitive care or the actual fix to their problem, then everything I do that's not en route to the hospital is technically taking time away from getting to the hospital. So minimize delays, okay? If they're not sick, then we basically can take our time. And Often, when they're not sick at one stage, we may find through a later assessment that they are actually sick. So what we're looking for here are really broad strokes of what does their underlying life status look like at the point in time you do it. If they're not sick, then we stay and play. That means that I'm going to stay on scene a little longer than if they were sick and try and figure these things out. I'm okay delaying things on scene because they don't need to get to the hospital that rapidly, or at least not yet. Now, if I start off thinking that they're sick, I'm usually not going to be backing down unless I misidentified something, or I find something later that clarifies something I didn't have that information for in the beginning. But we do find that not sick patients sometimes get upgraded to sick patients. So again, this is at the point in time you do the assessment, and what we're looking for here are broad strokes. Our primary assessment will give us details. These are broad strokes. So what's in it? So what's involved is assessing the patient's level of perfusion. Okay, so that's essentially the fourth, fifth principle. That's the idea that I have enough pressure to deliver oxygen that's on red blood cells to the brain, and the brain is doing work with it. So we're looking at perfusion status, okay? If somebody is sick, they're going to have a problem with perfusion. When I say sick, I mean life-threatening. So we have this patient assessment triangle, or sometimes it's called the pediatric assessment triangle. That's actually where this measurement comes from, but I want you to use it on all adults. The goal here is to make sick or not sick judgment in less than 60 seconds. Okay, so again, across the room looking at my patient. So what can you tell from across the room looking at your patient? Well, we can tell the patient's skin condition, so mostly their skin color. We can tell their work of breathing, so that's how hard they are breathing, not necessarily a ventilatory rate, but does it appear that they really need to get more oxygen in their body and they're struggling to do so? And then we use their level of consciousness. Okay, so if I have good perfusion, my skin color should be normal, my level of consciousness should be normal, and my work of breathing should be normal. If I don't have good perfusion, and there's lots of reasons why we don't have good perfusion, we won't have that answer yet. We just know whether or not sick or not sick. Sick meaning problem with perfusion, life threats. The way this works is any one of these three things having an abnormal finding is enough to say sick. So with level of consciousness from across the room, are they awake? So we can get a very kind of just general, are they awake when I arrive, announce myself. Again, I don't talk to them to get this, just from my first impression of looking at them. When I arrive, they should know I'm there, right? So my eyes are on them. They should be able to see me. They should know I'm there, and their eyes should be awake. If their eyes are not open and they're not awake when I arrive, something might be wrong. So we're probably going to say this patient may be sick. If their LOC is normal, they're awake, look at their skin and their work of breathing. For skin color, I'm just looking for, is their skin that kind of proverbial pink? I won't necessarily be able to tell the temperature, so I can't say if it's warm, but I might be able to see if there's any sweat. Okay, if it's not pink, so the variations might be that their skin is pale, they may be mottled. Any number of variations in there, abnormal, tell us that we're having a hard time getting oxygen to the brain, and so we're shutting down blood supply to the skin. Lots of details on that later, but if their skin is not pink, as we would call it for that patient's skin color, then we would say they are not normal, and so they would qualify as sick. Work of breathing. If they're working hard, if they're working hard to breathe, that's sick. If they have a fast ventilatory rate, if they're in the tripod position, if I can hear audible sounds when I walk in the door, those are all indications that their work of breathing is elevated, and so that tells us that they're probably sick. So sick versus not sick, within 60 seconds, you need to be able to tell this because your whole call, your whole scenario is going to be dependent on this. So practice this, though it's not a check sheet when you're doing your scenarios. This will help you make that determination. As soon as you know, say, hey guys, for your team's purpose, right, for your scenarios and your proctor's purposes, though the patient may not need to hear this, hey folks, this one might be sick. Why don't we go ahead and start off thinking we're going to transport? So can somebody get the gurney? All these things have to happen before you get in the ambulance and transport. So we start minimizing the delays in those things immediately as soon as we identify. And again, I can change my mind later once I do more thorough assessments, but this starts the tempo of the call. And if I find something that contradicts this or clears these things up, I'm going to find it probably in my primary assessment. So that's the doorway view, utilizing what we'll call the assessment triangle with LOC in one area, skin color, and work of breathing. If these things are not normal, only one of these things abnormal means they're sick. If the other two are normal and one is abnormal, they're still sick until proven otherwise. If all three, well, then they're just even more sick, is kind of the idea. And it doesn't matter which one is abnormal. If any one of them is abnormal, they're sick for now. Okay? You should be able to tell skin color, pale, normal color from across the room, maybe diaphoretic. You should be able to tell how hard they're working to breathe. Maybe I didn't count their ventilatory rate yet, but how hard they're working to breathe. That should be something you can do from across the room. And do they acknowledge my presence? Are they awake when I walk in the door? I don't know about alert and all these other details I'm going to get in my primary assessment, but are they awake to somebody who they called 911 for, someone called 911 for them, and is unusually arriving at their house, knocking on the door? That should prompt their attention. Now, the primary assessment begins when you greet your patient, whether or not they talk back. Once you're within the distance of being able to touch them, talk to them, communicate with them, that's the stage of primary assessment. So again, primary assessment might be annotated as a 1 with the degree sign next to it. Secondary, which we'll do a little later, is a 2 with the degree sign. So what's the goal? The goal of the primary assessment is to identify immediate life threats and treat them. So as mentioned previously in other slides and videos, I mentioned that we find it, we fix it, and we move on. That's our mantra. We learn these likely as ABCs. And so really the primary assessment is A, B, C, D, and E, but we often just talk about the ABCs because that's where a lot of our work is done. So what we're doing is we're getting a gauge for their core vital signs to determine whether they have an immediate life threat. And from all of this, we're going to get something called a general impression of life threats. That definition's a little bit later, but GILT, we call it, general impression of life threat. This is basically another time to determine whether or not they're sick or not sick. Here, we'll determine are they sick or not sick based on our primary assessment and either confirm or change what we came up with in our doorway view. For the general impression for this life threat, we're going to have to put this together with some context and with the findings that we find from the patient. And sometimes we need to get other people involved, like bystanders, to answer questions for unconscious patients or family members to answer questions for unconscious patients. Don't forget that when patients are unconscious, you should check their wallets, check their personal belongings. One, it's part of your safety to know what's on them because they're going to go in the back of your ambulance. And if they wake up and you don't know what's on them, it may be a bad scene for you. But two, you'll be able to get their name, their information, maybe from their driver's license. And some patients have medic alert tags on them that tell you that they're allergic to things, that have certain conditions. And others have in their wallet bits of information from their medical history or lists of their medications as well. And then now in the technology world, you might even be able to find some of that information on their iPhone or their Android device, especially if they've set up the in case of emergency setting, which should be pretty clear on their phone, especially when you go to shut it off, especially on at least iPhones anyways. So when getting our general impression, this is when we're doing our primary assessment, we're going to want to note age, sex, and race, level of distress as they appear in front of me, their overall appearance. So not just these ABC vital signs, but what do they look like overall in total? And can the patient talk to me? Because that will have an impact on how I assess them otherwise. The patient's position, we may need to change it. So if we find, for instance, a patient that's in the prone position, we can't really assess them until they're in the supine position, so we may need to move it. We want to avoid standing over the patient when we do these things, partly because, one, it's unbecoming, it's bad form, but also if you trip while you're standing over the patient, you're likely to fall on your patient. Any injuries they incur from you falling on them will be your responsibility. Always address the patient by their name, and if you don't have their name, ask them or someone else around them or try and figure out what their name is. If they want to be called by something else, make sure that that's something that they're kind of consciously telling you and not them confused about a situation because their brain isn't functioning. Always introduce yourself. So introduce yourself by first name. I wouldn't usually give your last name. Give your first name and then let them know what level of license you are and that generally you're there to help. We talked about in communication having to ask about chief complaint. Sometimes it's not clear to us. The chief complaint, though, for documentation purposes, you cover this in clinical, the chief complaint needs to be in their own words. So often it is not the precise diagnosis that we give. So for example, a patient might say they have chest pain, and we assess them, and in the end of the assessment, with all our tools, we say, I think they're having a heart attack. Their chief complaint is chest pain, if that's what they said. And use their words. Don't say, I have angina, which means chest pain. Don't say that unless they literally said that. So this should be their words, right or wrong, what they said is wrong with them. And then we're going to give our diagnosis, we call that our rule out, so something we'll talk about later, but you've already introduced in clinical because of your charting. And then we can call this presumptive diagnosis, or in the case of what we've just talked about in this slide deck, nature of illness might be essentially the cardiac chest pain that led to you suspecting they have a heart attack. We always need to address these life threats immediately, at least before we move on to the secondary, but hopefully find it, fix it, move on. So I do airway, find a problem, fix it, move on. Breathing, find the problem, fix it, move on. Circulation, find the problem, fix it, move on. So with each stage, we want to fix those life threats immediately. When assessing in your general impression, this is again stuff you can do from across the room. What's the patient's skin color and condition? Part of that you might get when you first shake their hand or take a pulse as well. And then from the basic information we get in our primary assessment, we want to determine, are they stable or unstable, or are they stable but potentially unstable? Stable means technically that their vital signs aren't going to be changing anytime soon. Okay, delta is the identification, the abbreviation for change, so it's a triangle. Unstable means their vital signs are changing and they're risking that they're likely to put the patient's life at risk. And stable but may progress to unstable is somewhere in between stable and unstable. Okay. Now, to say somebody is stable by itself isn't a great descriptor. So it's telling us about how their vital signs are changing over time, not necessarily about their overall condition. But generally, when we say someone is unstable, it generally means that they are ill. Okay. Level of consciousness is assessed in a few different ways. And so when we assess the level of consciousness, the first thing that we do is assess something called Avpu. Okay, this isn't on our ABCs as A. This is technically, we have A, B, C, D, and E. D is for mental disability, so that's where we assess the LOC. The LOC, when we first assess it, is going to be using something called Avpu. Now, you probably have learned these things by reading some of it in your book, some of it in lab, maybe supplemental skills lab, some of it clinical. So let me just clarify precise terms because they're testable. So when we're looking at Avpu, this is only going to tell us what did it take to cause them to open their eyes. Okay? So Avpu is the thing you did to get them to open their eyes, nothing beyond that. They don't need to speak to be verbal on Avpu. Verbal means you spoke to them and then they opened their eyes. They don't need to say anything. They don't need to understand anything you say. It's purely what's their eye opening about. And I say this because if you learn it right, it makes this easier to learn when we learn the GCS later for LOC. Okay? Sometimes it's taught that Avpu is they have to wake up and talk to you about it, and then we have to clarify things. No, Avpu is just what opens their eyes. So A means their eyes were open. They were alert to my arrival. I didn't have to do anything. So that's the normal status if we kind of show up in somebody's home for an emergency. V means I had to verbally say something to get them to open their eyes. Okay, so I announced myself. Their eyes weren't open when I walked in, but I said, hello, fire department, EMS, knock, knock. That verbal communication should then open their eyes. If they don't, then it means they're progressively lower on their level of consciousness. P is the next step down. So if somebody's not awake, they should open up their eyes when you talk to them. If they don't open their eyes when you talk to them, then we give them painful stimuli. Now be very careful because you don't want to cause pain to this patient in the sense of damage or discomfort. It's a small bit of discomfort that should wake them up from a very deep level of unconsciousness in most patients. So the painful stimuli, we're going to first probably teach you the sternal rub. The sternal rub should be done just enough to see if they open their eyes and wake up. We do this if they didn't wake up to the verbal stimuli. We now provide painful stimuli to cause them to wake up. There's other ways to do this, though. The trapezius pinch is one you'll read about. And then you could do things like check to see if they respond to light pressure on their cuticle. There's lots of ways to do this. But essentially, that should wake them up if they're sleeping or deeply unconscious for non-medical toxicology or trauma reasons, right? They're just really a deep sleeper. Pain will wake them up. U is unconscious. So we get to this, if they failed to have their eyes open when we're there, when we showed up, they failed to open their eyes when we announced ourselves, they failed to open their eyes when we provide pain, unconsciousness is the lowest level of consciousness, okay? So we're going to use Avpu all the time, and then sometimes we'll input it into a GCS score, which I'm going to give us a little bit later. Think of the GCS score as being the next level of assessment in depth of their level of consciousness. What if they did open their eyes to verbal? It doesn't mean they speak. It doesn't mean that they understand what you're talking about. We can further assess their consciousness, their neurological status, after we've determined what their level on Avpu consciousness is. Patients may be conscious with an unaltered level of consciousness. That would be our normal position. Patients may be conscious, like awake, but they have an altered level of consciousness, and then patients can be deeply unconscious. And so altered levels of consciousness are where we really concern, and unconsciousness are really where we concern with patients' airways, stability, and taking care of themselves. So when we assess an unconscious patient, okay, now this is again to say, if we have somebody in cardiac arrest and they need CPR, that's where we change things up and we go with CAB. But CAB does not mean circulation, airway, and breathing in the sense that we learn it for our ABCs everywhere else. So in order to get to CAB for a patient that's in cardiac arrest, you'd still have to do ABCs to figure out that they don't have a pulse. So there's a few things that we do. So I'm going to say this a few other times. We teach some of these things individually, but they're really practiced simultaneously, okay? So it is possible to check somebody's airway and breathing at the same time if their airway is actually already open. But when we have to address these things, that's where our stepwise find a problem with the airway, fix a problem with the airway, then assess and fix problems with breathing. So when a patient's unconscious or otherwise, we're always assessing airway, breathing, and circulation. And I want to say that this is our primary assessment. So again, it has disability for mental disability and expose and environment. So it's really A, B, C, D, and E for testing purposes. So don't forget that in your scenarios. D is where we do our LOC. E is the reminder to expose them as appropriate and to consider the environment. Patients that have sustained unconsciousness should warn you of critical respiratory, circulatory, or nervous system problems, the big three. And sometimes they're working together. Sometimes, though, it's as easy as finding one of these problems, fixing it, and then they'll regain their consciousness. So it all depends. When patients are conscious, but they're just not functioning properly with their ability to use their brain, it likely indicates that there's a perfusion problem. And so again, perfusion is that fourth Fick principle. It involves having circulation of blood, oxygen on red blood cells, blood pressure adequate to get oxygenated blood to the brain or wherever, in this case the brain, so that oxygen can cross over, and it does that through internal respiration. But also we can have patients that either the drug causes their LOC or the drug causes a change in their perfusion status. So we assess for these things in patients with altered LOC. All right, so I've talked about Avpu for you. Now, if I did Avpu, another level of consciousness assessment, so again, previously just to open eyes, if I want to know more when the patient opens their eyes and speaks to me, then we can do something called the orientation test. So the normal orientation test would be alert, this might be how you chart it, and oriented times 4. Okay, so that only should be written that way if the patient has no problems. So how do you assess this? Well, they should be alert, so Avpu, and then oriented to certain things. Memorize these things. Don't memorize these other names and really they're kind of puzzles and riddles that we give our patients that sometimes sound cool and we hear other people do, but they don't have a true purpose to this. So in order for this to work, you have to make sure everybody that's communicating with you and reading your chart understands the same 4 parameters. So if they're alert and oriented, everything is present, you can write alert and oriented times 4, which really means alert and oriented times person, place, time, and event. That's what that decodes to. So we ask our patient, do you know who you are? If they can tell us our name accurately, then great, they get the point for that. Do you know where you are right now? Even if they have to look around and they tell you, I'm in the back of an ambulance, but I don't know beyond that, if that's where you are, then great, they checked it. Time, roughly the time. If they can't tell you the time, but they look at their watch, that's a complex neurological process. If they can do that and tell you the time, then that's okay. Or if they can just tell you rough time, maybe they just woke up from unconsciousness, if they can tell you roughly what time it is, they get the point. Sometimes they don't. And then the event, can you tell me what happened? And then that kind of leads us into gathering the patient's history. So if they know person, place, time, and event, they get the times 4. If they don't, we can't write A and O times 2. If that's what we wrote on a chart and that's all we wrote it as, what would the person reading that wonder? Which thing is missing and which thing is present, right? If somebody doesn't know what happened to them, that might be a symptom of a car accident, right? Like the trauma of the event may have blocked out some of their memory, but they should at least know who they are. So these aren't all created equal. So if you don't know who you are, that's a deep problem with the way your brain is functioning. So instead of writing alert and oriented times 2, or just leaving it that way, you're going to say alert and oriented times. Let's say this person knew person, place, time, but not event. Person, place, time. And then put did not know event, or something along those lines. But just having a number here doesn't help. All right, so that's our orientation. Now, what I meant by earlier saying don't use other riddles is sometimes you'll hear people say to patients to test their level of consciousness, how many dimes are in a dollar? Or is Mickey Mouse a cat or a dog? Now, those sound cool, and for the patient, they're going to have to think about that for a second. But if they know, they could know the answer to those things and not know these things. And they could know these things and not know the answer to the question you're asking. So what does it tell you if you ask a person if they can tell you how many dimes are in a dollar? Well, if they answer that appropriately, they've got a lot going on. They can think about the question you gave them. They can process that into whatever thinking terms they use. Then they can break that down and identify that's a math problem. And then they can figure out how many dimes would be in a dollar based on essentially simple math in their brain. You're testing something completely different. That's a complex thing, but it doesn't mean that they'll be able to do the other things if it's present. Is Mickey Mouse a dog or a cat? Well, it's neither, right? It's a mouse. And so it's easy to trick people up with that. But their failure to answer that correctly has no bearing whatsoever on their alert and orientation test. So make sure the tests you're asking are at least the minimum. So you have to ask alert and oriented and all 4 of these questions if you want to ask those questions too. If you want to ask those questions too, great, but make sure they're not in place of. All right. When we get to assessing a patient's overall function, so if I ask them orientation, I'm really asking about their brain. I'm not asking them to do any work with it aside from thinking. What I mean by work with it, I'm not asking them to do something like follow a command. That's another level of complexity in a patient's level of consciousness. So one of the ways that we can assess a patient's level of consciousness in total is to use the GCS. So I'm going to say that every patient you assess gets Avpu. That's every patient. Whether or not we transport them or something's wrong, they're all going to get an Avpu. Every patient should get a GCS, but if the patient's going to be transported and treated, you need to make sure you get a GCS so you can compare it over time. If the patient's going to be refused, like they refuse to be transported, you need this for your documentation to show that they're with it. So Avpu is the requirement. Avpu is part of GCS, so you get part of it out of the way. And I want to strongly encourage you to do a GCS on every single patient. That should be the expectation in lab. Your charting will require that you have a GCS on patients that you're writing a chart on. So the Glasgow Coma scale is a scale. It's not listed here, but we'll give it to you. I'll give you a memory tool. It's listed in your book. It's also a part of your lab assessment. The GCS is a scale that has 3 components on it, okay? So some things to know about the GCS. The score you get out of this scale, the score on the scale is from 3 to 15. 3 is the lowest a person can get, not 0, and 15 is the highest. 15 is normal. Okay? If you're sitting in class right now paying attention to what I'm saying and I ask you a question, you can answer it, whether or not the answer is right, but you interact with me, you communicate with me, you're not confused. That would be a normal GCS and probably adds up to 15. So we have 3 areas that we use to get the numbers that we add up on the scale to give the score. So you want to be able to write the score down on your chart. We do this every time we do an assessment or reassessment. So it'll be basically the same as you'll include a heart rate. Every time you do an assessment on a patient, you should also include the GCS, okay? It's really helpful in determining kind of global portions of the brain's functioning. So to memorize the 3 categories, again, the scale's not on here, might be in a later slide, but let's just do it right here. There is it listed in your book. The 3 categories I want you to list just like this: EVM, okay, those are the 3 categories. E is for eye opening, V is for verbal, and M is for motor response, or basically following commands. So with the E, I want you to write a 4 kind of subscript next to it. The V, I want you to write a 5, and the M, I want you to write a 6. So when you memorize the GCS, first I want you to memorize EVM 4, 5, 6, and be able to just write that down at the top of your head. So you're like, okay, I got to calculate a GCS score. I don't have a scale in front of me. You will have to do that at some point. You'll be able to say, okay, let me write down EVM 456. The number 4 is the number of parameters for each category. Okay, so eye opening. Eye opening is nice. It's Avpu, right? Remember I mentioned earlier, if you memorize Avpu as what you do to cause them to open their eyes, it makes it easy for GCS. Okay, the scoring is the highest score for the eye section is a 4. Then the next highest is a 3, a 2, and a 1. So if I have a patient that I had to announce my presence for them to open their eyes, they're going to get a 3 when I do this score. Okay, so this is already built into you just walking up and assessing their LOC. You're going to do Avpu. That's the first part of GCS. The verbal is going to go through a set of ranges that have a total of 5 points. 5, 4, 3, 2, 1. Notice none of these are 0, hence why 3 is the lowest score, not 0. All right, so for their verbal response, this is what do they say to you. Okay, so you engage them. If they don't say anything, they get no response, which is equal to a 1. Okay, if they answer you normally, normal, that's a 5. The variations in between include the patient is confused. They say something, but it seems like they're not understanding the question or whatever it is that you're asking of them. So that's a 4. The number 3 is going to be they say something, but it doesn't really make a lot of sense. It might be like a replaced word, but nonsense. And then number 2 is they say something, but it's not really words. It's unintelligible. So I'll put non-word. Okay, again, you can see the whole scale and all the points listed on it. M is for their motor response. Okay, so you're doing a motor score here. And again, the 6 tells you how many max points you have. 6, 5, 4, 3, 2, 1. No motor response. They don't do anything with their motor, their body, right? Their muscles moving. They don't do any of this stuff. They get a 1. That's the lowest response you can get. That's basically like, as far as their body, like paralyzed or comatose. 6 is going to be they follow commands. So what's the command you give? Well, when I walk in the house, first thing I do when I meet a patient is I extend my hand, gloved hand, and I shake it or give them a fist bump or whatever. In American culture, again, there may be cultural considerations, so you have options here. But in American culture, if I extend my hand, they're likely going to extend their hand. If they do that, they're following a subconscious command. My verbal language didn't say shake my hand. My nonverbal language did, and they carried through. That's a pretty high level thing. I mean, it's like docking the space shuttle with the space station when you think about linking hands together, because using so many different muscles, your brain has to be aware of where your body is in space, where that person's body is in space, where my arm is in space, and how to meet them, so that I can have a smooth transition from my brain thinking of moving my arm to shake their hand to actually shake their hand without spastic movements and all these different things. This is a very complex thing. So if they can just shake a hand, that gives them a high score on the motor response. Now, once we start going below, though, it's kind of hard because the memorization isn't just going to be they don't follow command. It's kind of more purposeful for that. So if I reach out to shake their hand and they don't shake my hand, or I ask them to follow a command, can you touch your nose, whatever, if they can't do that, then I'm going to have to follow up with probably their localization of pain. Okay, so on this one, I'm going to kind of go down the list here and say, assume that you did something that if they don't follow command, then you do something like a sternal rub or a trapezius pinch. Based on doing that, they should say, I don't like that, doesn't feel good, and they should withdraw from pain. Or I'm sorry, they should localize pain. Number 5 is localize. So that means that if I'm laying on my back and you do a sternal rub on me, it happens on your sternum. If I localize pain, I reach up and I grab your arm, and basically that tells you I don't like it. I responded to the painful stimuli and I know where it's happening. I localize pain. Number 4 is the next level down. So I didn't localize pain and I didn't follow commands, but when you did a sternal rub, I withdrew from it. So this literally means that if I do a sternal rub on their chest, they're not going to reach up and grab it. They're not going to necessarily say anything. They're going to move their chest inward away from my hand, right? So that's something that they can do when they're not fully conscious to help show you that they don't like it. They should be doing that if they're not fully conscious because it doesn't feel good. Now, number 3 and number 2 are part of something called our posturing. Number 2 and 3, I want you to memorize in 2 terms, right? So you're going to memorize a term that's kind of a short term for the position they get themselves into, and then you're going to memorize the actual medical term, okay? So I'm going to have to expand, just don't have enough room to write this here. So we have 2 forms of posturing. We have decorticate and decerebrate, okay? Decorticate, I want you to get from this, has the word core in it, like your core body, right? Decerebrate is the opposite. Okay, so the other term for this is decorticate is going to be flexion. So know that when you're doing your GCS score for the motor response, number 3 is flexion, aka decorticate. Number 2 is extension, so it's worse than number 3, extension, which is the opposite of flexion. AKA the opposite of decorticate is the cerebrate. So what does this mean? I'm not on camera right now, but there's pictures of this in your textbook. The idea is I want you to look at the picture with this description, or say this description when you look at the picture. When you see flexion, it means that the person is laying on their back, and when you provide painful stimuli, they don't localize it and they don't withdraw. So instead, their response is to bring their arms in closer to their core, and their toes may be pointing away, okay, and their legs are like tight and extended. So they flex their arms closer to the core. That's the flexion part. In decerebrate, they're worse off, so they don't protect their core. Instead, they do the opposite. Their arms extend. So flexion, you bring your arms closer to the core. Extension, their arms are turned outward. Often their chest arches a little bit. So the idea here is when you do this sternal rub on the patient, when you're checking their motor response, if it's not normal, if they don't do the withdrawal or the localizing of pain, then they're at least going to try and protect their core by bringing their arms closer. And again, these patients are unconscious. So they bring their arms closer to the core to say, hey, I don't like that. I'm protecting myself. But with decerebrate, they're so far down the line, just not fully like paralyzed or fully comatose. They're so far down the line that they still have a response, but they're not protecting themselves at all anymore, right? If I bring my arms closer to my core in flexion, I'm technically still trying to protect my vital organs. But with extension, they just let you have it. They put their chest out, they put their arms away from them. There's nothing protecting their core whatsoever. So decorticate posturing is better than decerebrate posturing. Each of these, though, is pretty bad. It means that they're now functioning on the very, like, I don't want to say vegetative, but animalistic portion of their brain, and they're not going to have any higher processes, including protecting their own airway. So again, the lowest score even a dead person would get, they're unconscious and unresponsive, so a 1. They have no verbal response, so a 1, and they have no motor response, that would be a 3. So you add up the value you found for each of these 3 categories, and that becomes your overall GCS score. You want to check this and check your GCS over time. So maybe in 1910 it was 15. Maybe at 1915 on reassessment is 14. Over time, you'll see that changes might happen that you don't see from one to the next, but you see over a period of, we call it trending. All right, so if their LOC is low, rather their level of consciousness is not normal, then they're going to likely have issues at least with their airway, which is why we learned about last week, and then they may be at risk of these other life threats, okay? So these things may or may not necessarily go together. They're not in an order that happens together necessarily. So that's to say that patients can have respiratory arrest without having any airway issue. Shock can occur with no airway problems whatsoever. So these are just a list of things that cause sudden death. But let me put them into perspective. Airway obstruction is anything that blocks the airways that we've talked about so far. So that's the upper airway, and in our lower respiratory tract, that's going to be the trachea and the bronchioles, all the way into the alveoli. Respiratory failure versus arrest. So respiratory failure, when we do see respiratory problems leading to death, if the respiratory problem happens, usually they go through respiratory failure first, and then they go into respiratory arrest. Respiratory arrest, just like cardiac arrest, means they stopped. So respiratory arrest means they stopped breathing, and that often will lead to their heart stopped beating. Now, some patients just have cardiac arrest. They stop breathing when their heart stops. But in some cases, patients will have enough of a respiratory disease or problem that it leads to their heart stopping, but first will come them stopping breathing, and then no oxygen gets in the body when they're not breathing, so then the heart goes without oxygen. Eventually, the heart and the brain will die. Shock's definition, we talk about this in medical, but we talk a lot about it in trauma, is inadequate cellular perfusion. So in layman's terms, that means we're not getting enough oxygen to the cells, and we're talking about our core organs like our brain, which will go to the death phase of cells that are irreversible outside of 6 minutes without oxygen. Severe bleeding is one type of shock, and so severe bleeding leads to inadequate cellular perfusion because we don't have enough blood in the blood vessels to help carry the oxygen, so then we won't have perfusion, so then we can't deliver the oxygen to the cells. Primary cardiac arrest means that their heart stops beating for some reason, and that's why they go into cardiac arrest, as opposed to they stopped breathing and then eventually their heart stops secondary to that. When we're managing patients, we'll find most of these life threats often through our primary assessment. Now, when we're managing patients that are in cardiac arrest, it is appropriate to treat circulation first, and there's another time that we treat circulation before ABCs, or rather outside of the order of ABCs, and that's with trauma. So in some ways, you might hear described for you trauma starts with CAB, but that's not the way we should be thinking about it. So really, I want you to just to make it easy for you, no matter what anyone else says, CAB is only for CPR, okay? And it means that we do compressions in CPR before we manage airway and breathing when their heart stops, okay? Any other problem, we're going to do ABCs. Now, trauma is ABCs as well, and there is a circulation component before this, but we're going to memorize it as X, A, B, C, D, and E for trauma. Medical, A, B, C, D, and E. All right, can be confusing if someone doesn't describe that, so let me take the time. And now we've got a section on airway, all those things to consider. So this is really broad strokes, and the tools that you need, the tools that you need you're going to get from the airway lecture and from lab. So the goal is to determine that an airway is open and adequate. So that means when we say that airway is patent, that means the patient's maintaining their own airway, right? It's open right now, and I don't expect that to change. Could always change, but based on what I'm assessing, I don't expect that to change. So the patient should be able to move air in and out of their airway without abnormal sounds, and that means if they have a patent airway, they don't have snoring, they don't have gurgles, right? They don't have blood in their airway, right? They don't have a hot dog or some other external thing. The airway is open is our normal finding. If it's not, when you assess it, you need to fix it so that it is open before we can go on to breathing. I've said that a lot, but it's something that we need to memorize and practice in lab. Now, a nice thing, though, is that when we have patients that are awake and they're talking, if somebody is talking to you without having abnormal sounds in their voice, then their airway is very likely open. So often when we assess a patient that is conscious and talking to us, we don't have to do a very advanced airway assessment because we can see that if they're talking to us unobstructed, then their airway must be open. And so that's kind of this idea that patients that are talking or crying likely have an open airway. If somebody has a partial airway obstruction, like maybe they swallowed something and they can still breathe and talk, but that thing is still in the way, we'll still hear abnormal sounds like hoarseness or high-pitched sounds. So really what we're saying is we have no abnormal sounds and they can speak just fine. So listen to how patients speak and listen to how many words they say before breathing, okay? A patient without a problem breathing is going to be able to say a lot of words without taking their next breath, so we get full sentences out. But when somebody's got a problem with airway or breathing, they may not be able to speak in full sentences, and that by itself is a clue that something's wrong with their A or their B, and often it's both. Unresponsive patients, though, we don't know that because they're not talking to us, they're not awake, so we have to actually assess their airway. So you're going to open their airway with our head tilt chin lift or our jaw thrust maneuver, depending on what circumstances we have. Do we suspect there's a spinal injury or not? When we open the airway, you need to also look into the airway, so you may need to apply some light to do that. And when we look in the airway, we're looking to make sure that as far as we can see, there's no obstructions. We don't see any drainage of extra saliva, maybe blood in the airway, certainly foreign obstructions, or even that their teeth are dislodged would become an airway issue. When the person is deeply unconscious and unresponsive, the tongue relaxes, which becomes an airway obstruction by itself. We've talked a little bit about that. So patients that have an airway obstruction and they're unconscious may have something in their airway that we can see, but there's a lot of airway we can't visually see, right? Everything below the level of the back of their throat, when we look in their mouth behind their tongue, like just straight in, when we look at somebody without any tools except for a light, we'll be able to see just to that point. But there's a lot of airway that's below that. So we also use our assessment for sounds as part of it and how they're breathing. If somebody has an airway obstruction, their breathing probably is going to be impacted by it until we fix that. So breathing may be part of this puzzle or sign as well. Noisy breathing may be present from just standing across the room. Sometimes you can hear people snoring or even wheezing across the room. But we'll at least get this by assessing their chest, and in some cases we may need to listen carefully to their throat for the presence of these abnormal sounds. Any of these sounds indicate generally an airway problem somewhere within that entire airway tract from upper and lower. When we're assessing our patient's breathing with airway, sometimes, as I mentioned, we do these things together. So let me give you an example. Maybe the patient's unconscious. When I walk up to them, not knowing what's going on, I'm going to, at the same time, for an unconscious patient who I don't know whether or not they need CPR or not, I'm going to do a head tilt chin lift or jaw thrust maneuver, as whichever the situation implies. When I do that, I'm going to put my ear down next to their mouth, a few inches away, and I'm going to feel their pulse. I'm going to feel their carotid pulse at the same time I'm checking airway. If my ear is next to their mouth, I should be able to hear their breathing, so I can check all three at the same time. But I don't want you to do that and then fix only the breathing problem and skip the airway problem if both are present. If I do these at the same time, I still need to fix them independently and move from that. So you can see if I do this all at the same time, ear next to their mouth, head tilt chin lift, I looked in their mouth as I was moving my head towards putting my ear next to their mouth to hear their breathing. And here for any of these sounds, I'm also checking for a pulse at the same time. I can tell if somebody needs CPR immediately, and then CAB takes over, and I start with compressions. If they're not in cardiac arrest, they have a pulse, then I'm going to go through airway, breathing, and circulation. Ways to assess for the presence of breathing, or B on our ABCs, is essentially look for rise and fall in the chest. You may need to take off some of their clothing, especially winter clothing, to see their chest rise and fall. Feel for air through the mouth and nose. So this could be air that's going onto your cheek if you put your face next to them. Obviously, wear appropriate PPE. You might even feel this if you put your hand next to their mouth as well. And then we may, in some cases, listen to breathing with the stethoscope. Now, here's a catch. When we're doing our ABCs, this is all just introductory. I don't have time to look at details of all of these things. I'm going to get that a little bit later. Right now, is there a problem with these? So I can determine whether I need to fix it, and is this patient continuing to be sick so I can leave scene, okay? So when do you do this? So I have a rule. When I check a patient's breathing, okay, when I say that, that generally means just getting a rate, depth, and effort. So you get a ventilatory rate, and then you know whether it's using, is it labored, right? Is it shallow? All those things I can get when I check my ventilatory rate. But I can't necessarily listen to their lung sounds just by checking and counting their ventilatory rate. So listening to lung sounds involves a stethoscope. It involves more skill and it involves more time. So I would like you to use the stethoscope and listen to lung sounds in the primary assessment. So this is if in the primary assessment, use your stethoscope for breath sounds and lung sounds if these things are present. There's a problem with their breathing. So that could be an abnormal sound you heard from across the room. Could be they're working really hard to breathe. Could be their ventilatory rate is too fast or too slow, too shallow. Whatever that stuff is, if it's abnormal, I'm going to want to listen to lung sounds pretty quickly. And I do that in my primary. So I say, okay, what's the ventilatory rate? There's a problem here. I want to listen to my lung sounds right now. If their breathing is not an issue, then I'll listen to lung sounds when I first assess them if I suspect that there's an illness or injury to the neck. That's 360 degrees around, or 180 degrees around. So the posterior neck, anterior neck, doesn't matter if there's an injury or illness there. Listen to lung sounds. Chest, also all the way around, and upper abdomen. If any of those things have a complaint of pain, or I know there's an injury or illness there, I'll listen to lung sounds, because lung sounds can be very helpful in narrowing down specific diseases that cause these issues. And notice I didn't say just chest, because they may have lung problems or problems with their neck that indicate that they have lung problems. When I use a stethoscope to listen to breathing, I'm listening to each lung over each side. How you do that, there's steps in your book, and you'll be practicing that in lab. So I'll leave the steps for you, but when to do it. If they have an abnormal finding when I do my breathing assessment, so too fast ventilatory rate, too slow, abnormal sounds, abnormal work, whatever, listen to lung sounds right away. It might help you identify what's wrong immediately. If they don't have a problem, then I'll use lung sounds in my primary assessment if there's an injury or illness to their chest, their neck, or their upper abdomen. And again, that's basically all the way around their torso, any part of that. All right, so we talked about what's needed for a breathing assessment. When asking yourself about their breathing, you can use these questions to kind of help you get a feel for it. And these questions you should memorize and practice asking out loud in lab, but eventually they'll become internalized questions. Again, you're not going to memorize them and use them internally in the field if you don't practice them in the lab at the very least. So make sure you're going through these questions as a point of determining whether or not there's an issue. The patient's skin can indicate whether or not the patient has a breathing problem as well. And so cyanosis is to describe blue skin. It could be their whole body is blue, like when a person's not breathing, they turn blue and purple. It could be that they just have blue around their mouth, their nose, or their eyes. And so that could be, we would call it periorbital cyanosis. They could have cyanosis just in their fingertips. Either way, wherever we see cyanosis is an indication that those cells right there are not getting oxygen. And so when we learn a little later about how the body deals with responding to diseases and injuries, it often will shut down blood flow to less important organs that can survive for a while without oxygen, so that we reserve the little oxygen and blood that we do have for our brain, our heart, and lungs, which we know don't last very long without oxygen. Often that involves the skin shutting down. So if the skin shuts down, it would result in the skin going without oxygen, so it turns pale, and then without oxygen over a period of time, it'll eventually turn blue in color, okay? That's a bad sign. If they're blue, they need oxygen immediately. Patients speaking complete sentences, I mentioned this earlier, but the idea is if they can breathe, they'll be able to speak in complete sentences. They can say words without having to take a breath. But if they speak like this, okay, so maybe the sentence is normally said, does the patient appear to be choking? Just as our example. Somebody who says that who's short of breath may say, does the patient appear choking? So that's a whole sentence, but it took multiple breaths to say it. And so we call that incomplete sentences, a good indication that they aren't getting enough oxygen. And then, as we mentioned, lung sounds in the presentation. If I find a problem with airway, I fix it with airway issues or airway tools and maneuvers. If I find a problem with breathing, I have to ask myself then, is their problem because of a lack of oxygen, or is it because they're not breathing right? If the person is not breathing right, like breathing here really means ventilation. If my problem is with ventilation, then I need to fix that with the BVM, okay? Breathing problems with ventilation equals BVM. I may or may not hook that up to oxygen, but if I have a problem with oxygenation, right, not ventilation, so that means their breathing is normal, but they're still not getting enough oxygen, then I'm going to use oxygen supplement, okay? If I give oxygen to a patient with a supplement that's not a BVM, and their real problem is that they're not breathing right, then the oxygen isn't going to help because their breathing problem is still the issue. So if they have a problem with breathing, ventilation is fixed with the BVM, okay? Oxygenation is fixed with oxygen. Sometimes I need oxygen with my BVM, but oxygen won't fix ventilation on itself, okay? As mentioned on that slide, always treat the patient, not the numbers. Here's an example of that. Oxygen saturation is not an exact science, and it's prone to error. I mentioned previously that oxygen saturation is just measuring how saturated each binding point in the red blood cell is where oxygen normally goes. And so in some cases, it could be 100% bound, but not to oxygen. So aside from those cases, usually we're looking at oxygen saturation in the sites. And so a normal range is 94 to 99 or 100%. The higher in altitude we are, the harder it is to get that much oxygen into the body. So in higher altitudes, we see lower normal ranges in our presentation of patients. Below 94% though means that I need to intervene with oxygen, okay? But that's just a number. So treat the patient, not the number, means that if I have a patient that clearly is having a hard time breathing, but I put pulse oximetry on them and it says it's 100%, I'm still likely giving them oxygen because I can see they have a hard time getting oxygen. Their pulse oximetry may not be accurate. So when in doubt, treat your patient, not the number. That's the idea. When do I ventilate for my patient? Well, the parameters of normal ventilatory rate are one thing, but then our parameters of actually taking over their breathing are different. So we're going to ventilate, use a BVM. That's what this means. That's a tool. We're going to ventilate for our patients when their ventilatory rate's higher than 28 or less than 8 breaths a minute. In the range of 8 to 28, in that range might be abnormal. So 10 would be abnormal. But it may be that I don't need to actually breathe for them in that range. It may be some other issue. But if they're breathing less than 8, they're not ventilating frequently enough, so they're going to need help. Otherwise, they won't get the oxygen in their body. They're breathing 28. They're breathing so fast that they're breathing shallow. They're not getting the right volume of air in their body. So even if we had oxygen, it still may not fix the issue. BVM is where we intervene. All right, I'll let you read through the assessing of breathing. You're practicing that, but we also want to note the rhythm. A note here, though, we use 30-second periods to measure ventilatory rate and then multiply whatever number of breaths in 30 seconds by 2. But I don't want you to do not use 15-second intervals. I say that because, as you probably have already learned, when we're checking a heart rate, we can use 15-second intervals to check the heart rate and multiply it by 4. The problem here, though, is that the normal ventilatory rate is so slow that if I use a 15-second interval, I may only count 2 breaths. If I do that, I may miss any patterns that are present. So a pattern is going to present itself when you have more of something happening over time. If I have a short, ventilatory rates are normally slow, so I need a little bit longer period than the heart rate to see. Heart rates can be checked in 15 seconds because the average heart rate is 60 to 100 beats per minute. In 15 seconds, I can see how many of those beats are causing a pattern often and be able to deduce it, but not when we have smaller numbers like our ventilatory rate. And then I'll notice later, you can always count for a full minute if you're not sure about what you're seeing in the 30-second. And then obviously 15-second for heart rate, I can count for 30 seconds or even a whole minute if I'm not sure that I'm seeing the right pattern. So pattern is our rhythm, and rhythm needs to be noted. Again, it can be very helpful, like finding chain Stokes. But if I only count for 15 seconds, I'm probably not going to see the pattern. All right, good stuff. How to assess for breathing, I'll leave that to you. I do want to give some definitions. I'll play for us in the respiratory lecture when we're live, these sounds. But wheezing by itself is a medical term for a high-pitched sound that comes from the chest, not from the throat. Although it may sound, that's where, when you listen to lung sounds, it'll tell you exactly where it's coming from. Wheezing means that the bronchi have constricted. So normally our bronchi have smooth muscle in them, should be open, that's dilated. But in asthma and other diseases, the inside of the bronchi gets smaller because the muscle starts to constrict. This causes an increase in the pressure moving through that space and can cause a high-pitched sound, which we call wheezing. Wheezing indicates bronchial constriction. Okay, we don't treat wheezing. We treat the underlying problem of wheezing, which is bronchial constriction. So we don't have a medication called an anti-wheezing medication. And we don't give albuterol for wheezing. Wheezing is the sign that we'll hear to indicate bronchoconstriction, because albuterol is a smooth muscle, a bronchodilator is the best way to put it, a bronchodilator. And so it's not wheezing that we're treating, it's the constriction we're treating. And we reverse that with the bronchodilator. Now, rales and rhonchi have AKAs. So AKAs, these might be called crackles. That's kind of the newer term for them, though both terms need to be useful. Memorize both of these terms for it. So let's start with rales and rhonchi, and we'll talk about what kind of crackles, okay? So rales is a very fine sound. What you're hearing in rales is sound happening at the alveolar level, which are super small, right? So often if you hear rales, it's going to sound very well described as pinching your hair between your fingers next to your ear and rubbing it together. Almost that fine, sandy sound that you get when you rub those hairs together. That's our rales. We call that fine crackles. So no interchangeably. Fine crackles is rales, rales is fine crackles, and generally it means there's fluid in the alveoli. The sound that you're hearing is the air trying to move around that small space and the fluid that's in it. Now, rhonchi generally happens above the alveoli, and so rhonchi is going to be a little bit rougher sound, so we call that coarse crackles. Coarse crackles, not coarse like that, so coarse crackles, meaning rough, right, not fine. Coarse crackles kind of sound a little different. So instead of hearing a fine sanding sound as you hear with rales or fine crackles, rhonchi actually sounds like big bubbles. In fact, if you want to hear rhonchi externally, like, not in a real patient, then just imagine trying to like drink up something like a milkshake with a straw, right? It's going to be bubbly. You get to the end of it, you get those bubbles when you're drawing up the last bit of it. That's kind of what rhonchi sounds like. And rhonchi is usually mucus or fluid that's not in the alveoli, but in the bronchi. So it's a little bit higher in the airway. Larger airway spaces, so larger bubbles are making their way through and causing the crackles. So rhonchi are called coarse crackles, rales, fine crackles. And you can, by the way, have both present in patients that have fluid in their bronchioles and in their alveoli. Stridor is another high-pitched sound, but this happens in the upper airway. So think of this as being above the level of the vocal cords. It can include the vocal cords, so it's really not coming from the trachea or below. Wheezing is from the chest, the lower airway. Stridor is from the upper airway, okay? Stridor is present when somebody has something stuck in their airway, so often it's present with choking, and it almost sounds like a high-pitched whistling. It does sound different than wheezing, and stridor you can generally hear without a stethoscope, often from across the room when the patient is breathing. All right, depth of breathing is important to know. So deep versus shallow. The deeper somebody breathes, the more air they get into their lungs, the more oxygen will be capable. And when they breathe deep, they generally exhale to reverse that, so they'll blow off more CO2 in the process. But if we breathe shallowly, which means kind of less than our actual tidal volume, then we don't get as much oxygen into the depths of our lungs, so not as much oxygen going to our bloodstream. And when we exhale, we don't exhale as much CO2 because our initial breath was more shallow. In addition to breathing, we have some accessory muscles that can be used to help us breathe. So your primary muscle of breathing is going to be your diaphragm. Sure, your intercostal muscles, the muscle between your ribs, can be part of that normal, but we wouldn't see that change unless somebody's really using them. So accessory muscles are muscles used to help with breathing that are not the diaphragm, essentially, and they're something that you can see working when patients are really trying hard to breathe. And so as we try hard to breathe, we do some things like we may increase the size of our nasal cavity so more air gets in. That's called nasal flaring. Seesaw breathing is when the chest and the abdomen are moving during breathing in opposite directions. You can breathe with your chest, you can breathe with your abdomen, but when we see seesaw breathing, like a seesaw in the play yard between abdomen and chest, when you see this, it's often in children and is an indication that they're working really hard by using their abdominal muscles to help breathe. In addition, we have muscles in the neck that we can use to help breathe. Anytime you see these accessory muscles, including muscles between the ribs really sucking in, those are all indications that the patient can't do this and get enough oxygen in their body on their own with normal breathing, so they're recruiting these methods. All these methods involve more muscle, right? All muscle needs energy. So if I need more muscle, I need more energy. And if I need more energy, I need more oxygen. So the more they work to breathe because they don't have oxygen in their body to try and get it in their body, the more muscles they're using, which burns more oxygen than they're bringing in their body. So it makes the breathing process less effective. We want to try and fix that as much as we can. In this patient, you can see a few things. A little bit of nasal flaring, mouth is open, and if we saw them move, they might be bobbing their head up and down. We can also see that there's some depression here. We call that sternal retraction. And it's hard to see, but there's a little depression here in the sternal notch. This might be easy to see in patients especially. So that's the space that's basically at the shoulders. Those accessory muscles would show kind of like a depression inward, like a dramatic depression inward as they contract. Then there's also the use of positions. And so patients usually can breathe in basically any position that they're in pretty well. But once we start losing our ability to get enough oxygen in our body, we change our position. One of those positions is called the tripod position. So that's imagining the person who's kind of got like here's their feet, they're sitting on a chair, here's their buttocks, here's them sitting upright normally with their hands down, right? In tripod breathing, that person's going to be bent over and their hands often on their knees as they sit forward to open up their chest cavity so they can breathe more. Sometimes patients will be breathing in a sniffing position, in which imagine you're moving your head forward to sniff a flower, but just your head moves forward, not the rest of your body. And you move your head forward to sniff a flower. That's the sniffing position. Respiratory failure is when the body has gone without oxygen enough that the muscles are starting to get tired and failure will progress to arrest. Okay, so failure is a bad sign. Our goal is that when we find patients with respiratory problems, we intervene hopefully well before arrest. The sooner we intervene, the longer it will take them to get to arrest. So just giving oxygen and ventilation maybe even stops the process of them going towards arrest through failure. So the progression usually is the person breathes a lot, they get fatigued, their respirations start to fail, so their muscles are going to fail, that's failure. And then they progress to respiratory arrest. Once they stop breathing, eventually they'll go into cardiac arrest. Because again, if they're not breathing, they're not bringing oxygen into the body, so the heart won't get any either. Circulation. When we move on from breathing, we move on to circulation. Circulation is made up of a few different things. So first, I want you to know that when we're checking circulation, we're really checking circulation and perfusion. Right? Circulation is just movement. We also are going to want to take into account blood pressure. Now, in the primary assessment, we usually do not do an actual blood pressure because it takes time, especially when we're talking about trauma patients. So that means that we have other tools that can tell us whether or not a person has adequate perfusion, i.e. blood pressure, to get to their brain. One of those things is mental status. Remember when we talked about our doorway view, we use mental status or level of consciousness to tell us whether they're perfusing. We talked about what happens when their LOC changes under the D portion of A, B, C, D, and E for LOC checks. So if their mental status is not normal, it could be an indication that their perfusion is not normal. And so it probably will require us giving them oxygen and maybe fixing whatever their perfusion problem is. Their pulse can tell us about their circulation and perfusion. So pulse, not just basically their heart rate, the number you get, but the strength, how strong it is. The stronger it is, the more perfusion we have, right? The weaker it is, the less perfusion. And location. As we talked about in the human body, we have a few different pulse areas. One is carotid, that's the central pulse. We also have a femoral pulse, that's a central pulse. And then we have peripheral pulses. And the further we get away from the carotid or femoral pulse, the less that pressure should be. But if I do have a radial pulse, a distal pulse, then I probably have a good carotid pulse. So that's to say that we may not know our blood pressure number by the pulse location, but if I have distal pulses, I probably have an adequate blood pressure perfusing the brain, right? If my body didn't shut it down and stop having a peripheral pulse, start shunting blood to the core to protect the brain, then it must be getting enough with the pressure it has. Skin condition tells us about circulation as well. So we check the skin for skin color. Pink is the normal color, and that's regardless of what their underlying skin color is. Pink means kind of normal skin color for that patient. We're going to check the dampness, right? So is this really dry? Are they sweaty? And then we're going to check their temperature. Warm, hot, cool. Normal skin condition, meaning I have good perfusion, is to say that we have pink, warm, and dry skin. Again, regardless of what skin color they have, like ethnicity-wise, regardless of the skin color they have, normal would be pink, warm, and dry. Resist the urge to write down this, PWD, because that could mean pink, warm, and dry, or it could mean dry, or it could mean pink, warm, and diaphoretic, which is the medical term for sweating, diaphoretic. So that's not dry. So we don't want to necessarily write pink, warm, and dry as an abbreviation PWD unless we're sure the reader knows that D doesn't mean diaphoretic. Okay. So P could also mean pale, right? Pale, warm, and dry would be PWD. So your best bet is just to write this out when you're assessing, and then you should reassess skin just like our other ABCs every time you assess them, because you're going to check a pulse every time you check circulation. Physically, you need to touch the patient, check a pulse. Don't use a machine for this. Don't replace it with a machine. And when you touch them, you can tell their skin condition. All right, so how to check the pulse and what we're looking for, that stuff is part of your lab stuff and part of your reading here. When checking the pulse, remember that we palpate the pulse. That's the medical term for feeling, touching the patient to see if there's a pressure with that pulse. And then if you can't palpate a pulse, then the patient may not have one and you have to start CPR. So this was giving rise to the idea that if my patient is awake, I'll generally start checking. So awake A on Avpu, I'm going to check a distal pulse first. So radial is usually my choice. If they're anywhere below A, instead of checking a distal pulse, I want to check distal at the same time as carotid. And the whole purpose is to be able to identify that if they don't have a carotid pulse, I'm going to start CPR, but they may have a carotid pulse, just not a radial pulse. And so when checking the radial pulse in an unconscious patient, I check both so I save time. So I check the radial and the carotid. If both are present, great. I don't need to start CPR. But at the same time it took me to do both, I can tell whether or not I need to start CPR. Now remember, circulation is for assessing. We're not talking necessarily about bleeding or CPR here. That's what the other acronym like CAB is for. Here's a normal range of pulses, and so this is the pulse range that we'll be using to test on as we go through the term. Right now, I want you to focus on the adult pulse because we'll be learning the pediatric pulse again and testing on that more specifically when we get to the end of the term and cover pediatric medicine. Bounding and thready pulses are worth describing. So a normal pulse feels like it's got a good thump behind that pressure wave that you feel. Abnormal could be even stronger than that, so you can have really like pronounced, but usually it's the other direction, it's weaker. And so a pulse may be weak if it's not got a lot of pressure, and then if it's really weak, it might be thready. So thready is hard to memorize unless you kind of know what you're looking for. So what thready describes is, imagine you're feeling a pulse, right? So you're feeling, say, the radial pulse, so you have your fingers on the skin. Thready feels so faint that it's like having a piece of thread, like sewing thread, that has knots tied in it running under your finger. So imagine that fine sensation of tiny, tiny knots running under your finger is the strength that you feel when the pulse thumps. If it's that weak, it's thready, and that usually means that pulse is going away soon because their pressure is so low that you barely feel it wherever it is that you're feeling. So weak is bad, but thready is worse. Okay, thready technically is weak, so you can imagine there's different degrees of weak. We're also looking at regularity, so patients' pulse rates may be irregular, though one of the most common but not important to like worry about irregularities is associated with the person taking breaths in and out. And so when you take a deep breath in, you put pressure on your heart, that will temporarily kind of change the way your heart works and may pause that beat or make it really, really weak. So aside from noticing whether or not that pausing happens when they breathe, irregular means that it doesn't march out. It's not thump, thump, thump. It could be any variation of thump, thump, long pause, thump, thump. So there's still a pattern. So it's an irregular pattern, but there's still a pattern. Or it could be completely chaotic. There's no pattern whatsoever. Skin color is important for us to assess because it tells us about our perfusion. And the reason it does this is because if the patient, as mentioned earlier, has a decrease in perfusion globally, they'll suck blood away from their skin, their bones, their muscles, and we call it shunting it, putting it into the chest. And so they literally will close blood vessels in their skin to draw blood closer to their heart, lungs, and brain so that whatever perfusion, blood, and oxygen they have present, they can take care of those first. Your skin and your muscle, they all die at varying degrees without oxygen, sometimes multiple hours without oxygen. So the body can sacrifice them for a little while, but it can't sacrifice the brain. When the body closes off those blood vessels, so the blood vessel was open wide like that, blood's going through, it causes vasoconstriction and the blood vessel gets smaller, and so less blood goes through it. That blood ends up staying in the core. But the result is less blood going through our blood vessels in our skin means that we're no longer going to be pink. The pink color doesn't come from their skin color. It comes from the fact that our blood vessels that have blood in them are going to give rise to that pinkish color of our skin because the blood vessels have red blood cells in them. And our skin, even if it's darker skin, that skin is still almost see-through when you look at it under a microscope. So you can see the red color of their blood circulating through those blood vessels. But if we close them off, you can't see that anymore. So the first stage is that the patient becomes pale, right, when those blood vessels close. Same condition as when a patient is really cold. They close off their blood vessels in their skin to shunt the body temperature to keep their blood warm inside their body so their brain and hearts and lungs will survive. After pale goes on for a while, though, we might end up cyanotic. Okay, so pale happens before cyanotic usually. Cyanotic is that blue color, and that means that not only did we shunt away, but the cells are now starting to show that they don't have oxygen, and it may be the start of those cells becoming sick. We can also have other skin colors, like the opposite would be maybe the blood vessels aren't normal size, but they get even bigger, they vasodilate. Now I have even more blood. That would make the skin flush, which is basically just red in color or flush. So you can see it's a spectrum that we can find. So normally the skin would be pink, warm, and dry. Capillary refill is a measure I'll let you read about, but to know when to use it. Capillary refill is not reliable as an indicator of perfusion in older patients, when patients of any type are cold or they are in a state of shock, because we measure this at the fingernail. If they're shunting blood away from their fingernail, then the cap refill is not going to be accurate anyways. And so cap refill just tells us how long it takes for blood to get back after we depress it. In a person that has great perfusion, cap refill will be really quick. If they don't have good perfusion, meaning they've shunted blood to their core and closed off blood vessels to a degree, it'll take longer for blood to go back into the finger. Capillary refill can be really helpful in children that are not really cold or in the presence of shock. Good stuff. So this patient actually has what appears to be a redder skin. They're a little bit darker skin as a baby, but the bluish color that you see around the eye and around the mouth up here, that's called cyanosis. And this in particular is what I mentioned earlier, periorbital cyanosis, or cyanosis around the eyes, nose, and mouth. This means that they're lacking oxygen in kind of the core areas. This is concerning. They could have normal colored skin on their face and have blue on their fingertips, which is a little different degree of shunting away. But if they shunted blood away from the skin here, it means that they're probably in a really desperate situation. So oxygen is what we need to provide. It turns blue because oxygen is darker blue when blood cells are darker blue when oxygen is not present. Normal skin temperature is 98.6 degrees Fahrenheit. That's for all age ranges. We do have an equivalent that is in centigrade, but we don't measure Celsius rather. We don't measure that and convert that at our level. So you're expected to know the Fahrenheit version right now, but in medicine it's metric, so usually we're using the Celsius. You can convert it. There's converters you can buy for your phone, so on and so forth. But for right now, I'm just looking at 98.6 degrees Fahrenheit. It is a range, but we're going to look at that specific number for now. That should be the temperature that we feel as warm to the touch when we touch somebody's skin. Dry skin is normal. We can have too dry of skin, and so that's marked by the Turgor test. I'll let you read about that in your book. But it can also be really wet. And so wet often means that we have excess amounts of sweat. As a medical term, sweat is called diaphoresis. So that's the act of sweating, diaphoresis. And if they have sweat, we call them, not that they're like actively sweating, but if we see sweat on their skin, we call that diaphoretic skin. Okay, if they're sweaty, it could mean that they're dealing with temperature, but it could also mean that they're dealing with some stressful situations in their body that resulted them in showing this sweating. So for example, a patient may be diaphoretic if they have a low blood sugar value as well, though they're not really dealing with the temperature issue. I'll let you read about capillary refill as well. Now, this note about controlling bleeding is an important note. The idea with controlling bleeding is that we want to make sure. Hold on one second. Sorry, I got a. Sorry, I got a text from my wife to check in on that. The additional bleeding here is not to really go with C, though. I want to make a caution, okay? So you'll learn about bleeding here, but as it goes to patient assessment, I want you to memorize A, B, C, D, and E for medical patients, okay? For trauma patients or bleeding patients, we use X, A, B, C, D, and E. And this is pretty new, so not all of our textbooks reflect it. The X stands for exsanguination. Okay, exsanguination is a medical term, so EX, that's where our X comes from. Exsanguination means to bleed completely out. If a person loses all the blood in their body, right, they lost that through some hole in a blood vessel or in their body. They could bleed internally and have none in their bloodstream. They could bleed externally, have none in their body or in their bloodstream. So we add the X here to remind us that when we're assessing a patient in our primary assessment, if we see that they're bleeding externally, we don't wait until the C, circulation, to fix it. We have to fix that soon. There's a lot of the stuff that goes into trauma with this a little bit later, but I just want to give you this kind of idea. If I don't fix the bleeding, but I move on to airway breathing and circulation, it still won't matter, because if I let them lose red blood cells, which carry oxygen, and I still let them do that as I'm caring for them, they're continuing to bleed, I don't stop it, and I move to airway, and I fix their airway so I can get oxygen in their body, and I fix breathing so I get breathing in their body. When I do those things, the oxygen is just going to go onto the red blood cell that's just going to leave the body. And so it's a waste of effort and time. So we always control major bleeding before our ABCs in the presence of patients that are bleeding. So that's often going to be our trauma. I don't want you to rememorize CAB, so then you think, okay, circulation and bleeding first, because that's not what we do. We just fix the major bleeding, and then we do our normal A, B, C, D, and E. So you'll be checking your heart rate in patients with major bleeding when you get to the circulation section. Again, it may be all at the same time, but by just nature of having to fix the bleeding first, this X is going to be your key. So when bleeding is present, you should memorize X, A, B, C, D, and E, and not A, B, C, D, E, or C, A, B. All right, an important characteristic. Now, bleeding from blood vessels depends on the size of the blood vessel because they depend on the pressure that's in that blood vessel. Arteries generally have higher pressure, so blood is going to spurt from them, and veins have lower pressure, so they kind of have a steady flow. The larger the blood vessel, even more volume will come out. So a small artery may spurt more blood than a medium-sized vein, but a large vein can lose a lot of blood quickly, though it's not spurting as a key. In addition, when we see bleeding coming out of veins, it's usually dark in color, red. When it's coming out of an artery, it's bright red. Controlling external bleeding is an entire section, so we have a bleeding control lecture that we'll go through. This is the basics, so I want you to review this. We will talk about specific steps and how to do them, and you'll practice them in labs. So just kind of a gist for right now, because we're going straight into medical. We won't talk a lot about bleeding until a little bit later. So again, remember, we're doing ABCs so we can get the guilt impression, general impression of life threats. We can manage sick or not sick, and we can treat signs and symptoms and life threats emergently. So in the flow of things, I want to kind of give a caveat after you get through A, B, C, D, and E. Once you get your guilt assessment, before you move on to your secondary assessment, there's a little kind of thing that happens. It's in your guideline that shows you the steps of doing a scenario or your medical or trauma assessments. But it's basically, once you get your general impression of life threat from your primary assessment, you need to make a transport decision. Okay, so this literally is to say, this patient's sick, we need to leave right now, I'm not doing anything else till we get the back of the ambulance. Or to say, this patient is not sick, we can do more here on scene and transport if we decide that they're sick. Same qualifier, do they have a life threat, as we used in our doorway view. Now maybe I walked in and I saw they were pale, and that told me they're sick. I do an ABC assessment and I find out they're pale, but all the other perfusion statuses are fine. They're pale because they're sick. They have an infection. Okay, maybe their infection isn't shock or a life threat, but maybe still made them pale. So in that case, I would say, okay, I went from thinking this was a sick case to a not sick. That rarely happens though. Usually you walk in and their doorway assessment is normal. So I say not sick. I hang out. I do my primary assessment. Like, oh my God, I found a problem. Now I change it. So whatever it is, you transport then and do your secondary assessment and treatment and everything else en route, or you're able to stay on scene and you do your secondary assessment on scene. So that's an important note of where all this is going before our secondary assessment. Rapid scans are important, especially when we're managing patients in trauma. So you're going to learn for your trauma assessment that you do a head to toe, and the head to toe assessment is really, really in-depth and detailed. We don't have time for that in our primary, so that technically is a secondary assessment. When we're assessing our patients that we suspect have trauma in the primary assessment, instead of doing the head to toe, we're going to do something modified by doing a rapid body scan. And so really all we're doing here is to just quickly look over the body, just lift up the shirt if you need to, roll them, look at their back, do those things so you can identify whether or not their major bleeding is present. and if it is, you fix it then and there. So the body scan is really just to see if there's major spinal injury or bleeding during the primary assessment. What we call the head to toe is a secondary assessment tool. And don't mix them up, because then you'll fail and maybe kill that patient by taking too long on scene when you should be transporting to the hospital, where in trauma anyways, trauma surgeons will do the work. Determining the priority and care of transport, that's the idea of determining based on your primary assessment, do I rapid transport sick patients, or do I stay and play? I stay on scene, take some more time, do some more assessment, and maybe transport later. You should only stay and play on patients that have no abnormal findings or life threats in their primary assessment. If they have a life threat or an abnormal finding, even if you fixed it, it probably is indicative of something bigger. That patient's probably going to need to go to the hospital, and rapidly. If you can't fix their life threat, they definitely need to go to the hospital, and the sooner they get there, the better. All right, so I'm going to pause here, and I'm going to let you go through the rest of these slides for reading purposes, and then I'm going to start up our next portion of the video as we talk about gathering history and our secondary patient assessment.